Welcome everyone to yet another episode of the Para Podcast. I'm your host, Tulani Thomas Sibanda, and as always, I'm joined by my co-host, Mr. Malusi Mtetwa, and Mr. Elias, who's in a new location. Can I say Habibi? Welcome, Habibi.
Have a go at it.
Habibi. So together we are the voices behind the Para Podcast. Now, before I introduce our very special guest today, I wanted to share a little bit of a personal anecdote. Is that throughout my journey as a student, and even after qualifying, I've encountered people often saying, asking me if I'm related to our guest today, a certain prominent figure in emergency medical services in South Africa, or they would ask me if I knew him personally.
You actually do look alike. And the ambitions are also alike. So yeah, just say yes. Just say yes.
Maybe now I'm gonna say yes. My uncle.
Maybe this is the time for the facts, for the truth. The truth can come out now.
What did they say?
Kumbuleka,
For a long time the answer was no, but now it's yes.
You start rumors, Tulani. You start rumors. I'm sure you don't want to do that.
But my first real encounter was with his work. It wasn't my first real encounter with him wasn't face to face, but it was rather with his impactful research that he has done, which was titled "Work Conditions and Experiences of Emergency Medical Services Personnel in the Department of Health in Gauteng and in Northwest Province." I actually read his work when I was doing my master's, which was related to burnout, and I sort of read some of the stuff that he's written, which I could relate when I wrote my master's. Now, Dr. Sibanda is the second of 4 children raised in Soweto. He's a paramedic who initially aspired to be an architect, a passion inherited from his father and shared with his younger brother. However, circumstances led him to paramedicine, where he excelled, acquiring many qualifications, including a PhD in post-traumatic stress disorder, which he says is a topic close to his heart. We'll unpack later why is it a topic close to his heart. Driven to make a difference, this novice author published his first book. I'm not sure if novice is the right word now. Maybe I know too much because. Let me leave it there.
Let's speak to novice.
This novice author published his first book, From Soldier to Doctor, a journey through life of hardship and hard work. I think he published it in November 2024. And the reason why he published the book is to inspire others facing adversity, and is currently working on his second book. That's why I said novice, but not like novice. Just to continue, is that his 33-year-old career in emergency medical services began in the military at the age of 19, where he became a top performing student as well as a lecturer, earning the name of Prof. He held many key managerial positions at the Tshwane municipality, Northwest EMS Gauteng, as well as Mpumalanga, and currently serves at the Limpopo EMS since the year 2018. Dr. Sibanda has contributed, my uncle, to over 20 provincial and national committees, possessing extensive knowledge and training and management, mentors aspiring paramedics, and has helped individuals achieve their master's degrees. He is also a member of the Golden Key International Honor Society that recognizes his academic excellence. Now, anyone that receives this, the Golden Key International Honor, is that you have to be invited. This honor is the society in the world's largest collegiate honor society, recognizing top academic achievers, which says a lot about him. You cannot just be a member. Membership is by invitation only and typically extends to the top 15% of college and university students, as well as top performing graduate students. And with that said, is that Dr. Sibanda, we want to welcome you to the Para Podcast team and thank you for honoring this invitation.
Oh, thank you very much. That's quite an introduction and very intimidating, if I may put it that way. Because such introductions actually create an expectations from you. So, but thank you very much for the eloquent and thorough introduction. And I would like to greet all your viewers. Good evening.
All right. Look, we're not gonna start off because we've spoken about your journey into the EMS.
Yeah.
If you can run us briefly, how did you get into emergency medical services? I know we touched briefly on the introduction, but how did you end up getting into paramedicine?
It was actually by default. I think after I matriculated, I stayed for a year at home, and basically after that year, I decided I'm not going to stay at home. I'm not going to be on another forced what the millennials call gap year. So I decided I'm going to do something about it. So I started applying for every job that I came across because I wanted to do something with my life. And the military then advertised positions for training in the medical sphere. So we applied, but at that time, we didn't know that it was for the military. We just saw they wanted medical personnel to be trained. So we applied, and then on the 24th of January, I still remember, 1992, we reported in Pretoria and we were met by brown trucks and soldiers and giving us instructions and shouting at us. And so we must get into the trucks and we're going to the military base. And it was a very scary experience because, I mean, you left home knowing that you're going to train as a paramedic. You get there, there's people in brown uniform and you ask yourself, what is happening? But we took the journey. We went to the training academy, and when we got there, it was actually even worse because now we were in the camp and they were starting to shout and they shouted with vulgar words that I cannot use for for the listeners because for those who knows the military, they don't beg you, they tell you what to do and you must listen to what they tell you. I think you had an interview with Mr. Musiani who briefly touched on the training in the military, and that's how strict it was. So that's where the journey started. And after training in our basic training, we were then taken through the medical training, and that's when I realized that you know what, I think I'm going to like what I'm doing, even though I didn't want to be in medicine. My first passion was to become an architect. But due to circumstances and the systems back in the days, I found myself in the military.
I've got a question. Sorry, Turan.
Yes.
It's two-folded. Back in the day, there used to be military services.
Yes.
Where you finish your year 12 metric, and then you're forced to go and work for the military.
Yeah.
Firstly, do you think that is necessary? It can help us somehow with the young people? That's the first one. The second question is, there's a trend that I'm noticing. You spoke about Mr. Mosiane was also in the military. You are also from the military. I've seen a lot of leaders emerging from the military. Is there a way that the military fine-tunes people to become good leaders? And what do you think about that? So it's those two questions from me for now.
Okay. The military transcription would be a good idea, but since they changed the constitution of the country, it's going to be difficult to force people to get into military transcription. To become to go for the training. The training is actually good because it teaches a whole lot of discipline. And remember, back in the days, it was a year transcription. or 2 years transcription. And for the 2 years, they taught a lot of discipline. And some of them, when they got out of the military, they became very good leaders, if I may put it that way. Um, and to answer your second question, yes, it contributed, but we cannot all be the same. It also depends on you, because discipline is an inherent thing. It's not something that somebody can come and teach you. They can just come and polish it. So if you're well disciplined yourself, you'll then be able to come out as a better leader, because we've got guys that were in the military, and some of them when are outside of the military. When you look at them and they say, I was in the military, you will be shocked because of their behavior outside of the military. Yes, in a way it does, because of the discipline that they teach you. But things have changed since back in the days to now. You cannot do the things that we used to do in the military in the past. You cannot do them now, because you'll then be taken to task. I remember post 94, when we wanted to punish some of the troops. And I was called to the general's office to say, why are you punishing these people? You're going to get yourself into trouble. Yet, pre-94, we could punish anybody at any time that we wanted, and we would not have a problem. So, things have changed, and there's also representations by unions and all that. That has changed the shape of the military to an extent that the troops now have a voice. If they don't want something to be done unto them, you cannot do it, and you cannot force them. And when you give them punishment, you're going to get yourself into trouble, because you have to have a limitations. Where else in the past there was no limitations, they can do to you whatever they wanted to, and it actually brought out very disciplined soldiers then. So that's the difference between the then and the now.
I wanted to say maybe that's why we have the Mapenas now.
Well, you know what? You're not far from the truth. You are not far from the truth.
I think we need to add a clip of what the Mabena is somewhere here. Clip on audience. So they can understand
you
what the Mabena is.
you must try and find it and put it in there.
No, South Africa milk the Mapena jokes, so
Yeah.
it's fun to have those clips here and there.
Yeah.
Going back to your history, and in your book titled From Soldier to Doctor, you did say that you by default you ended up in paramedicine. Now looking back, what are the aspects of paramedicine and emergency medical care ignited a passion in you that perhaps architecture wouldn't have had?
In architecture, you deal with drawing buildings and bringing them to life through construction and so forth, and you'll be happy that you know what, I drew that building and so forth, and that's it. But in paramedicine, I think the one aspect that changed everything for me was the fact that I could save a life. And the very first one that I had was a resource in a casualty in Sebokeng Hospital whilst I was on my practical phase. It was a female that came in, and on the table she arrested. And when she arrested, we had to initiate CPR. So I was put on the chest and I was pumping chest, all the time. And when we saw that woman walking out of the hospital, a few weeks later, that's what changed everything for me. And I felt very proud because I contributed into her going from an asystole into a fully walking patient that went home and lived her life like that never happened. And that's what changed everything, because I then realized that with medicine we can make that change to a person's life, not buildings like with architecture. And that's why I started developing a passion, and I said to myself, you know what, I think I need to study further, do research more, and find more information so that I can better myself. Because remember, at that time, I was then selected as a lecturer, and I needed to be better than the students. So I then went out into searching for information. Then I didn't know it was research. I was just searching loosely for information that I could find and putting it together, learning from that, going to speak to nurses, doctors, every medical person that I could find, and gathering all that information. And that's what made me a better lecturer over a period of years. So that CPR, that first CPR that I did, which became successful, was the change for me.
Now, look, I think one of the unspoken things in paramedicine that you've highlighted is that, um, and the rewards of paramedicine is that witnessing the full circle of care, especially after intervening in a life-threatening emergency, and where, as I said, it's unspoken. Is that it gives you that ultimate validation of what we do, as you've expressed, is that you saw that patient walking out of the ED after I was discharged from systole. But also for me, I think it fills a gap where you get to, because sometimes we don't know about these patients, about the outcome. But at that time, it gives you that sense of closure to say, okay, we did well on this patient, and the patient was discharged out of hospital. And it's emotional relief and fulfillment that you've also articulated for us when we manage these patients. And thanks for sharing that experience that you had. And your book description highlights the significant hardships, including navigating the apartheid system. I think it's important that we need to talk about this. We're sitting with greatness, but also you come from an era where there was the apartheid moving to freedom, I think post 1994. So in your book, you describe or you highlight the significant hardships, including navigating the apartheid system. Can you share a specific challenge from that era that shaped your approach to leadership and patient care in emergency medical services?
I think the specific challenge that I had is the skin color that I had.
But you could not hide. It was every day.
Everywhere, because even when you were getting into training institutions, your color mattered. And if you're not of the right skin color, you would not enjoy certain privileges. And I had to navigate, because I remember in one of the CCA courses that I attended, I was the only black student amongst whites, and we were 10 in the class. So you can imagine the challenge that came with that, and even outside of that, in the provincial colleges, you had to have the right skin color. Even during the practical training sessions, we were treated differently because of the skin color that we had, and all of that, made me actually look at things differently. To say, one day, if I become a leader, I'm not going to be like the people that treat others badly. And I can assure you, I'll give an example. I remember there was a time when I was still in Swami. One of the guys that was an instructor at one of the colleges, um, they seconded him to the college, and he was an operational paramedic. So he came back into operations. And when he came back into operations, they said, you must go and meet your boss and tell him that you are back in operation. The guy was white. So when he got into that room, into the office, and he found me, and he says, "No, I'm looking for, the district manager." And I said, "I am the district manager." You won't believe what I'll tell you now. The man resigned a week later, because he felt that he will not report to a person that he had taught all the work, and now the person is going to be his superior. So he resigned a week later. But when I left Gauteng and went to Mpumalanga, the gentleman rejoined Gauteng EMS. Very funny. So, and I all of that then shaped me into the person that I am, where I started saying, you know what, we need to empower our African brothers to make sure that they can go further. But the problem is we have some of our African brothers that we cannot want to put in the same pot because of they've got whatever motives and so forth. But um, when I got into a very senior management position, I decided I'm going to then motivate and mentor guys that are below me so that they can become better leaders, they can become better paramedics, and also trying to create opportunities for people to go and learn. Because remember in the past, when EMS was still attached to the fire stations, this was a predominantly white, male dominated service. And it had to change post apartheid, and we started seeing a lot of black males entering into the service, but they were only limited to a certain qualification class. Um, and then later on, we started having females into the service, which then changed the whole picture of EMS. And now we needed to then accommodate having females in a service, which also then meant that even with the ambulances that we buy, the equipment that we buy, we must make sure that females will be able to actually operate them and so forth, to a point where we ended up changing from the G3 class stretcher, the ones that we used to pick up and put in an ambo, and we changed over to the self-loading stretcher because of now we had females that could not lift the stretcher. We've seen quite a lot of them out there that struggled, and we had to get people to assist them. And this is not being sexist, but these are the facts that we had to live with. And then we had to come with changes to ensure that everybody is able to then, work in this environment. And that was, for us to accommodate everybody. So I've become that leader that always wants to see the change. And what it also did, I'll share with you, just 2 weeks back, I had new employees, in the department, at Intimidate Life Support. So I took them and I had an interview with them in my office. And I asked each and every one of them, where do you see yourself? What do you want to do with your life? And some of them don't actually have that ambition of where they want to see themselves. And I think it's because of the lack of mentorship. I then said to them, you know what? You need to start thinking about where you want to be and what you want to do with your life, because you cannot just want to be an ILS forever. You need to have that ambition and say, I want to see myself being, a manager and so forth, so that we can then put mentorship programs in place that will groom you towards becoming a manager. So that's the type of approach that I've implemented ever since then.
Wow.
I think, sorry, Lani, I just have one question, and I think it's around mentorship and sort of minority groups in terms of representation. Do you think as a country in South Africa, because, I still hear the cries of, not a lot of people are able to study further. First, because you can't work and study at the same time. And then two, there are other systemic circumstances that might not allow people, especially Black people, to get through the paramedic program, especially with around swimming. What are your thoughts around that? And do you think they are adequately supported in terms of that aspect? And just what do you think needs to be done in order to facilitate that? Sorry to put you on the spot, but I think I think this is a very important aspect, since we are speaking about ambition and growing and underrepresentation. And I think we are trying to push for representation in the service as a whole.
I'm going to take you back to yesteryears and also compare it to the current year. Back in the days, you were required to be fit, physically fit, and be able to go down the stairs, go up the stairs with a stretch and so, because some of the lifts cannot accommodate stretches. But things have changed from yesteryears to now, where we're now seeing stair stretchers that you can fold and put in an ambulance, in a lift. Some of the lifts are actually, have got more space where you can fit in stretchers and the likes. But I still believe I'm old school. I still believe you need to be physically fit in order for you to function in this environment. If you go to countries like China and the USA and so forth, those guys are always fit. I mean, you should see the competitions that they undertake, when you start looking at our guys, I mean, it's across the board. It's not only in EMS. You go to SATS, you go to traffic. I'm not going to say much, but the level of fitness has gone down the drain that we are not able to compete. If we were to have those competitions, we will not be able to compete with other countries because of the level of fitness. But in terms of it being used as a discriminatory criteria, I don't believe it should. Because we need to shift the focus and say, what am I studying? If swimming becomes part of rescue training, then it's fine. Let it be part of rescue training, because then there's water rescue and all of that. But don't make it a criteria that will fail people because they could not swim when you are dealing with emergency care where swimming is not, required. I'll give a typical example. For people that are in the rural provinces who are not next to the sea, do we need swimming? You know, we don't. We've got boats that we can use. We've got, all of this other equipments that we can use when we want to access patients. So why do we have to make some of this as a criteria that determines whether you pass or fail? Yes, it can be part of the criteria, but then let there be a swimming program in the very same course that teaches the students to swim if you want it to be a part of the curriculum, so that when they exit, they will exit knowing how to swim. Because um, there's especially in the black culture, there's that indoctrination that they put into our heads that if you swim you're going to drown, so you automatically fear jumping into the water. I mean, I've been with so many people as grown as they are, and they said, don't you want to come into the water? And they will tell you, no, I'm afraid that I'm going to drown. And it's about, how are you going to drown when we are here? We'll be able to assist you. No, 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 I'm afraid of the water, because of that indoctrination. And hence, I'm saying, if you want to put swimming as a criteria, then put it as part of the program, to say each and every afternoon, maybe on Tuesdays and Thursdays, they must have swimming lessons so that they can be competent at the end of the course. And then you can evaluate them, which is going to be a very fair approach.
Thank you for answering that bit.
I've got a question there, Tsilana, too.
Okay, go ahead.
I think it happens that most of the time when the news report anything, it's normally negative, and they don't normally focus on the positive and the things that are good that are happening in the industry. So obviously they want something that is going to sell, But now that also leaves the public having a perception that the leadership in the ambulance service is actually not doing their job. And you'll end up having people that are saying, look at this, like they will complain about post 94, and because obviously the ambulance service was covering the municipalities that were in the cities, and now they are covering the people in the rural areas, and the people in the rural areas don't get the ambulance sometimes because they are far. Now, how would you talk to that? I know that you are in one province, but in a place like Umtata or KZN, where sometimes an ambulance takes 8 hours to come or 9 hours, in terms of management, what do you think it's lacking in terms of that? What can be done to fix such issues?
I cannot say it's only management. There's a variety of other issues as well, and the one that stands out the most is the attitude. It's the attitude, because when we go to the clinical governance meetings, they will tell you about, your paramedics are rude, or the paramedics, the sisters are rude and all that. What does it boil down to? The attitude that we have towards each other. I normally tell most of the people that for people to take you serious, you must take yourself serious first and know what you are there for. So you must know your purpose, why you applied for the job. That is why I always say this job is a calling. If you are not, if it's not a calling for you, then don't join. Now the problem is we end up having people that join this service because they need an income, but the passion and the drive is not there. So hence I'm saying it's a variety of issues. There's also lack in management skills. I mean, take for an example, for one to become a manager in EMS at the base manager level, you're only required to have your clinical qualification. Where is the management qualification requirement? It's non-existent. So we need to also start fostering that to make sure that we come up with a criteria that will make people that wants to get into management to have a management qualification in order for them to manage better, because that's where it starts. And then also then have programs that will constantly tap into changing the attitude, and also changing the morale of the staff, because some of them are demoralized. If you look at the salaries that people are getting, it demoralizes a lot of them, and they end up saying, you know what, I'll go there when I have time, you know. And then there's also that interference. Sometimes you get political interference, sometimes you get interference from organized labor and all these other aspects, which also impacts on how the services will react. But then you get to other provinces, and you find that people are, highly motivated. They do their work and all that, and it's because of all the aspects that are in place to make sure that the service is managed properly, and that also then changes the attitude and also changes the morale of the personnel. There's the shortages of equipment and some of the resources that is needed for one to do your work, and I think but that is changing slowly but surely, because now budgets are being given for the procurements of equipment and all of that, which actually is improving the services. I'll speak for one. In Limpopo, there were times where our responding time was very poor, but it has improved drastically. So because of now there's an injection of funds and resources in order for us to meet and the response times, and it was purely because of um, I think some of them were tired to get scorned when they get to the patient very late, because then you get shouted at. Some of them are assaulted. Some are attacked and verbally and physically. So people ended up becoming very tired of such. So, but I think the situation is changing slowly but surely. There's positives out of that, because there's lessons that we've learned to say what is it that we did wrong, what is it that we can do correctly in order for us to move forward, and since we've started addressing those shortfalls, we are seeing that positive change.
Hmm. Last follow-up question. In terms of measuring the response times, how do you do that? Like measuring, because you're saying that there's an improvement. Is it measurable? How do you assess
Yes.
that?
If you understand how the response time gets measured from our national guidelines, it is from the time the person picks up the call and calls the call center to the time that the ambulance stops at your front door. And we make use of the patient report forms, because in the patient report forms, you record all the information that is necessary for you to measure. From the time that you receive the call and to the time that you become, mobile to the incident, to the time that you stopped at the house, and that's when we look at the times that you've taken. Now there's computer aided dispatch systems that will also give us that information, because the minute we give you the call and you become mobile, it starts measuring all of that. Then when we go to the dashboard, we're just going to pull a report that will give us from the time the call came in, that specific call, especially if it's a priority one, from the time that call came in to the time that the patient was attended to. Then we'll be able to get the time and then we record it, and because of the times stipulated, 30 minutes urban and 60 minutes rural, we then look at the call. If it's in a rural area, was it actually responded to within the 60 minutes time frame? If it is beyond that, then it does not fall within that criteria. But if it is below that, then it falls within the criteria. Then we measure in terms of the total number of calls that were received, which were P1s, what is the percentage of the calls that we responded to within the time frame, and then that's what gives us the measure.
I'll come and do a retrospective study in your
You should.
province.
You should.
Yeah. Kilani, before you proceed to the next one, I
Yeah,
had another follow up one. Sorry, Dr. Sibanda.
no
And
problem.
I think this just speaks to in our earlier podcast. I think Malusi mentioned something with regards to there is quite a large number of paramedics that are doing their masters and their PhD in South Africa, which is commendable,
Yes.
of course, which is good, which is the way to go.
Mm,
And I just wanted to know in terms of your area and in your organization when it comes to people that are within BLS and intermediate, because obviously we're trying to push them up, because it's easy for a paramedic to move to a master's or, and then
yeah.
explore a PhD. But then it always feels like all the odds are stacked up against you if you're an intermediate.
Mm, mm,
What sort of support do you currently have in place to make sure that, there is a transition? Because first of all, it's very difficult. You can't go study, obviously, because you're required to study full time. And most
mm,
organizations
mm,
do not allow you to study part time. So how are you sort of
mm.
like just supporting these guys to make sure that they jump these loops and go to the next, which is the paramedic, the main sort of like destination?
Um, First of all, academia is an individual journey. So you must have the passion. You must have the passion and the drive to go for it. You can take the donkey to the river, but you cannot force it to drink. Sorry to use that analogy, but it's a
Let's say a
fact.
horse.
Yeah. Okay, let's see. So, but you can take your horse to the river, but you cannot force it to drink. You know. um, Academia is an individual journey which you must be willing to undertake. If you do not have the passion and the drive, we can put all the systems in place for you, and you won't go anywhere. You know, I'll give a typical example. Um, there's somebody that came to me and said, "Hey, there's a course in EMC, PG EMC with the Western Cape University, and then we should apply and we should go for it and stuff like that." I applied and I studied. I think the person didn't apply, and but the person came and gave me the information, and I took the information and applied. So hence I'm saying, academia is an individual journey, but we're still working on putting systems in place, because remember, the systems that we need to put in place, we must be able to see the results of that. It's no point in putting systems and then there's not going to be any results. So we're still trying to find all different other avenues that we can put in place in order to see them transition from where they are into higher qualifications. Because remember, most of these higher qualifications are very new, and now, since there's affiliations with the higher education institutions, it becomes even more difficult, because now we need to fall within the criteria, the entry requirements of the higher institutions, higher education institutions. So now we need to conform and structure those initiatives to fall within those criteria. So it's a learning curve on a regular basis, but yes, there is that support there. But because of the constant changes that are happening, we find ourselves having put this in place, and then there's a change, and we start saying, "Oh, we didn't think about that." Now we need to start exploring, so that we can cover the change that has taken place.
Okay.
But in terms of them getting support from the department, we actually afford them leave to go and study, and it's actually paid leave, so they don't we don't stop their salaries and so forth. So we afford them paid leaves to go and study. We've got 5 now that are currently studying with different universities. Hopefully, when they come back, they'll come back with those diplomas and degrees. So that support is also there.
Okay. Sorry if I may just ask, usually is this like application or because is this application, or is it usually like you need to make, let's say, maybe 4 years in the organization and then you qualify for?
I think gone are the years where we need where we discriminate based on the years in the service. Anybody that's got a passion to want to go and study, let them go and study. Why should we say you must first have served so many years? We've got a retainer contract with them that when they come back, we retain them for a specific period of time as per the years of study. So why should we then discriminate based on how long you've been in the service? Anybody that wants to study, that has got the passion, let them go.
When we publish this, you'll have people knocking at your door.
And it's fine. They can come. We'll always give them all the necessary information that they need.
Yeah,
You know, I've always believed in one thing. I can give you all the information that I have
yeah.
and all the knowledge that I have. It's up to you what you do with it. You know.
Sure.
So look, we've had so many discussions. I've even lost my trail of thought. But one thing that we had an interview with Dr. Ravin Naidu. I think I'm allowed to say that.
Okay.
Is it?
Yeah.
Yes.
Yeah.
Yes.
We had an interview with Dr. Ravin Naidu, and probably when this episode comes, this one will already be published.
Okay.
There's something that he said to us during that interview. I'm not sure if it's in the interview or outside the interview. He spoke about the pistol pneumonic. And when you look at the pistol pneumonic, it's about what are the factors that can affect the macro and micro environmental factors that can affect the organizations. It can be applied to any organization. And we spoke about political, economical. If you look at the pistol pneumonic, it's political, economical, social, technological, legal, and environment. And when you bring it into the EMS, is that a lot of the discussions that we've had today during this episode are centered around, because there's politics that can affect the progression, career progression, or there's many other environmental factors that can affect people's career progression. There's so many things that we can talk about. But moving right along is that we've spoken about the career progression of the BLSs and the ILSs, or the junior qualified people. What I wanted to bring us to is that having served as a director in multiple provinces, you witnessed the evolution of emergency medical services in South Africa. What are the significant changes that you've observed in your career, whether both positive and negative, for paramedics on the ground?
I think I've touched a little bit on the significant changes, and one of them is moving from a white male dominated industry to a mixed sort of environment where we're now seeing both across all color bars, if I may put it that way, whether Indian colored, African or white, we have them as well as male and female. Because when we look at the percentages of females in EMS, it's no longer a very huge gap. You'll find in other provinces they're sitting at maybe 40% female and 60% male. So those dynamics and the changes are actually positive, because now we get hammered on the equity, in terms of hiring females in certain jobs. And I think we've moved very closer to achieving that. And then the other dynamic that change that I've seen is, I mean, back in the days, if you had CCA, you were glorified, but now we've got your diplomas, your PG dips, you've got your degrees, and then your PhD and the your master's degree and your PhD, which are the changes that during my tenure has seen developing and becoming a reality. And I mean, we've got quite a few graduates now that are PhD holders, which is actually a proud moment for EMS, because back in the days we were not taken serious with they used to call us we've got a spaza shop qualification, because of it was short courses. But you're laughing, and it's actually very serious. I was speaking to one lady the other day, and she was asking me and saying to me, Dr. Sibanda, I see you are in EMS. Are you a medical doctor, or are you a PhD
Sponsor
holder? And I
doctor.
said, no. Yeah. And I said to her, you know what? I'm actually a PhD holder. And she said, so you got PhD in EMS? And I said, yes, we do have. And she said to me, wow, I didn't know that you guys have got PhD. We must start respecting you guys because now. And she was saying it jokingly, but you can also see that we were so undermined back then because of the qualifications that we had. But now people are starting to take notice of the fact that we've got academic qualifications that matches all other qualifications out there, and we're starting to gain that respect. And those are the things that the positives that I've seen. In terms of the negatives, that might dampen the spirit of this interview. But well, um, I think it ranges from the lack of both human and capital resources. Because if you look at how some of the services are running, there's a huge lack of that, and mostly in a paramedic space, the advanced life support space. Yeah, because I mean, look at yourselves. Where are you now? And coming back home, we've got very minimal of, and especially the rural provinces, they cannot attract advanced life support because some of the paramedics don't want to work in the rural areas. Those that are coming here are people that they just want to come back home most of the time, and those that still has a passion and they cannot find employment anywhere. And then the other aspect is the sabotage. There's a lot of sabotaging going either between services or management echelons and stuff like that. The discrimination that is still there, the alienation that is still there, the character assassinations where you get discredited and so forth, the jealousy, and I can go on and on and on. So those are the negatives that I've seen because they end up making people focus on people instead of focusing at the bigger goal, which is improving the service. We end up fighting fights that we're not supposed to be fighting instead of us coming together and say, let's build the service. And how can we build it? Because we've got excellent people out there with brilliant ideas. But because of, you'll find a manager sitting in a high position when a junior comes with a brilliant idea. They say, but who are you? You know? Instead of listening to what the idea is, you look at who came with the idea. And that kills the spirit of improving the services and making it better.
I've got a comment there, Dr. Sibanda.
Yes, sir.
Recently, there's been a video that has been circulating. It's in America. I forgot which state, but there is an argument that a doctor is making, questioning why do
Texas.
Texas, these paramedics actually put on drips on people. They're not allowed to do that, and it then sparks a conversation around professionalization of the industry in that space, in that country, in the Donald Trump country. So
the cousin of Elon Musk.
Now, kudos to South Africans who have professionalized the industry very early. And we can clearly see the impact even of that globally. The fact that we have this opportunity of being here at the moment everywhere, like we are in different countries, it's because of professionalization. And it was easy for them to benchmark with the qualifications framework, national qualification framework, from the SAQA that we have in South Africa. So that's pretty brilliant. A second point on this, that was a comment. This is now a sort of a question somehow.
Okay.
Last time I spoke on the same interview now, I spoke about a retrospective study looking at the cases and how the response times and all those things. Can you imagine, Dr. Sibanda, having you in your department, one of the deputy directors that you have, and they just do research. They just do research only, and that is what they're focusing on. So there is the office of the research. There is a mine of data that is produced by ambulance service, but there is very less research output that we have. Imagine that the organization that I currently am working for is actually organizing something that is similar to have a person that is, they're going to have 3 people. I had on one of the conferences I attended in one of the universities at Flinders Uni. They mentioned that they're going to have 3 people in that department, and they're going to have people that are just responsible for research. I think it can change the industry a lot, because as much as we are doing these PhDs, if I come back to South Africa right now, possibly for a period of a year, I won't find a position that is suitable for me. I would have to do normal operation work, yet I have skills that can actually assist the organization. Now, if you think about it, now me being me, I'm thinking there are 9 provinces in South Africa, and you can have 3 people hired for each position, and you can have 3 times 9 people that are having positions that are academic, that are focusing in research, and that way we're improving the organization. I know this is me dreaming about the utopia of EMS sometime in the future. What do you think about that?
Yeah. I think it can work, but we first need to correct the scarcity of the skills, especially clinically. Now I'm
Yeah.
talking as a manager. I would not take people out of operations and put them in those positions because I need people in a clinical space. Um, if you hold that position but also still do clinical work, then it can work in a current environment in South Africa. As I said, because of the scarcity of the skill, it is going to be difficult to say, a highly qualified clinical person sitting in an office and only focusing on research. Should I say, a non-productive use of the skills. So for me, the research would actually change a lot because there's a lot of people that come to me. There's a guy that said to me, I want to do research for my master's, and I don't know what topic I should, come up with. And I said, what do you want to look at? And he told me what he wanted to look at. So I then churned out the topic for him, and I said, this is a topic that you can go for. And he said, wow, how did you think about it so quick? And I said, based on what you said, the one that I can think of that would actually suit the what you want to research is this. But then you need to go and do research to see if the research that you want to research is researchable. Meaning that you need to do all the due diligence to see that all the information that you're going to need for that research is going to be there or not. Yeah. To answer you in short, yes, we need such, but not with the current environment in South Africa.
Okay.
Hey,
I think I heard my last follow up. I know, Tulani, we are gonna eventually give you time to get in there. I think, and I think this is just on the ideal system, and I know you did touch on it a little bit, and Malusi did touch on it a little bit. But I think let's start dreaming here a little bit, and
Yeah.
let's talk about.
let's stop.
um, let's talk about advancing the system. And I do know that few systems around the world are doing things like this. Like, for instance, trying to sift through the calls that come in using AI and ensuring that, we utilize it to improve patient care as a department. And I know we are in Africa, but it's something that we can work on. Is there any talk or anything that you are planning to go for in that direction? Because I do know that one of our ministers in Namibia did say that they want to bring AI and augmented reality onto the ambulance. So I just wanted to know from your
You're
perspective.
laughing.
I'm sure you've seen it.
How should I?
um, there's the humanity rights aspect that we also need to think of. Who's managing the computer on the other side that is managing this AI? We don't want the Human Rights Commission coming into the picture and says, yeah, but you're impeding on to the human rights of these people. We studied what Italy is doing. In Italy, they've got telemedicine where when an ambulance lands at the incident and they pick up the patient, immediately they get into the ambulance and they close the doors. They get a live feed in the hospital. But then in South Africa, you cannot do that because we still have the Human Rights Commission that protects the privacy of the patient and all these other things. And in Italy, the laws are so relaxed because of it's medically related. So everything gets in by practitioners on the other side. But now the problem is in South Africa, we don't have the infrastructure for that in a sense that, who's going to man the camera that side? Is it the doctors and the nurses that are waiting for the patient? Wouldn't we have anybody that is not medically qualified also seeing that information, which will then start exposing patients, to people that are not medically qualified? So the patient confidentiality aspect will then fall away, and so we are not ready yet for that, if I may put it in short, until we start changing certain legislation and also find a way in which we can protect the privacy of the patients. Then we can start talking about such things.
I think what you've said, Dr. Sibanda, is quite profound. And this is what Elias also said when he did that interview with Eagle FM
Yes.
about the introduction of AI into ambulances. I think
Mm.
in most African countries is that the main thing now that is important is about service delivery, servicing the community, making sure that we achieve those response times.
Yeah.
Whereas once we've got that right, once we know that we've got that right, then we can look into innovative ways like introducing AI, introducing maybe even community paramedicine and palliative care. At the moment, emergency medical services, we need to service those communities. Now, we're running out of time. I just want to ask you something, and this comes to equality and equity, and you've mentioned it. Maybe not much more of equality and equity. Just two questions is that before we close off on this session is that I don't know, in my entire experience, and this is my observation alone,
Yeah.
to declare that I haven't seen a director of EMS who's a woman, unless you've seen it. I don't know if about Lucy in South Africa. I don't know about Elias. I haven't seen
Yes.
a director of EMS who's a woman in South Africa. But
Okay.
also, is there limitations of having women to become directors of emergency medical services? Are we not training, or not even just training? Training is the bad word, but mentoring females to be in those key positions to be EMS directors.
Yeah. Okay, to correct you, yes, we have a woman director in KZN, Nikki Wezungu. You can look it up, you'll find it.
Oh, yeah. I remember her.
She's been there for a while. Yeah, she's been there for a while. And we've even moved another step further to appoint a female college principal in KZN as well. So the principal is actually, yeah.
What's her? Do you remember her name, the principal?
It's Busi Arends.
Oh yeah, Busi, my friend. That's how she refers to me.
Yeah. So yeah, the changes are there. But now, Tulane, I'm gonna say something that sounds a little bit controversial, but it's not. When I was still working in Swani, I noticed that females are not acting in station manager positions. So I said for the two stations, I need names of females that are intermediate life support for them to act in those positions. Therefore, what are the names? I appointed them. And I called them to the office and I said, "Don't worry, guys, we'll support you all the way." And then so that you can, because I'm very big on mentoring and grooming. 3 weeks later, they send me letters and saying no, but they want to step down because they cannot stand the environment. It is just a hot seat for them, and they step down. So we still have challenges in terms of women managing males because males don't want to be managed by females in most instances. Even though the female might have the qualification and the requisites to sit in that position, a lot of males are not ready yet. In KZN, where it is predominantly cultured that way, I think that's where you'll find a lot of difficulties. Because I remember even back in the days when the HIV started becoming a pandemic in the country, when they sent nurses to go and do a training on the use of condoms, the males told them, no, you're not going to tell me anything. Who are you? I mean, I'm not going to take instructions from females. And it was a difficult one. So, but I think with the times changing like this, we are slowly getting to a point where we'll have females in managerial positions. Because now, in my province, we've got a few female station managers. So we just need to groom them to occupy higher positions by making sure that they've got all the relevant qualifications in order for them to function in those positions.
Okay. All right.
Now, Tulani, before you go, I have one, just one, and this is one, and I don't think it will feel right if Dr. Sibanda I leave you without asking this one. On this,
Okay.
Yeah, on this podcast, we do try and push for the well-being of the clinicians, especially
Yes.
working in this environment. It can be very stressful. Most of them are exposed to sort of like PTSD,
Yes.
anxiety and self-harm and so forth. I just
Yeah.
wanted to ask, is this something that the service pushes for in terms of protecting clinicians? Because we do get exposed to quite a lot of trauma. And is there any sort of like systemic sort of like management sort of like approaches that you use to ensure that you are fit? Because just like a car, take the car for service, make sure that it's fit
Yeah.
to be on the road.
Yeah.
What are we
Yeah.
doing for the guys that are on the road to make sure that they are strong and going and can endure the long period of practice?
Yeah, there are systems in place. We've got the employee assistance program, which is run by social workers that ensures that there's consultation on a regular basis in terms of the paramedics. But the problem is, and in actual fact, today we were having a talk about that with some of the directors from other provinces, and the challenge that we have is people not accessing those services. They don't want to go to those services. And I think it's the stigmatization part, because some think that when you go and consult a psychologist, you will be deemed as a crazy person, and they cannot differentiate between psychology and psychiatry. So they tend to think that if I go there, they'll call me a crazy person. I'll give a typical example. In Pumalanga, we came up with a program which was supposed to assist the employees, and then we were sending them to Jacaranda for psychological interventions and so forth. And this one morning, we had about 70 people that were supposed to go to Jacaranda. This one morning, the bus rocked up and it stopped. And as it stopped, one guy who was not part of the team that was supposed to go to Jacaranda Hospital shouted out and says, "Hey, here's the bus for the crazy people. All the crazy people get onto the bus." You know, so that stigmatization then makes people not to want to make use of the service. And
Sounds like something that will happen in South Africa.
yeah, it's a true story. And this is what led to actually, I think I shared that with you. The PTSD book that I'm writing currently, and I wrote it based on the fact that what I've seen happening in the industry, and I want to share it with everyone in the public space so that they can, start noticing the and also have toll-free numbers that they can call in and make use of the services unanimously without anybody knowing or seeing their faces, and that probably can assist so that you get referred as an individual and then you go and consult individually. Because when you come with a group approach, people start looking at one another in the room and says, "Oh, this one is here as well. Oh, that one is here as well. I didn't think that he can be here," And the stigma that goes with it is what makes people not to make use of the services. The services are there.
Yeah.
Thank you.
I will request Tulani to continue talking about this on the next segment, where we
Okay.
discuss it a bit thorough. I think we can let Tulani conclude.
Okay.
So yeah, just to conclude this segment, Dr. Sibanda, is that
Yes, sir.
thank you for honoring this invitation. And I think we've spoken about, there was a lot more to share, and there's still a
Yes.
lot more to share. And I hope our listeners find this very insightful and educational. Before we end this, I know we're running out of time, is that just for this segment, if you could leave our paramedic listeners with one final message,
Yeah.
their vital role in the healthcare system and their own personal growth, what would that be?
Um, I would say to them, they must know what they want and what purpose and what purpose are they serving, where they functioning, and then they must make sure that they go for it. And then also they must never let things that are happening around them deter them from achieving what they want to achieve. And then secondly, they must also make sure that they always improve themselves so that they can be better in terms of skills and knowledge, because they'll be serving the public. And, the one thing that I always say to them is maybe the next person that would need your skills and your knowledge might be a person close to you, which is your family member. So you'll never know. So go out there and always strive to improve and improve and improve yourself until you become a better paramedic.
Hmm. And on that note, I think it's important that you said that. You've said it very well. And we're going to close the show. To our guests, our listeners, thank you for listening or watching this podcast. And please follow us on our social media platforms on X, as well as our Facebook. And we are on all social media platforms together, including LinkedIn. But also, please subscribe to our YouTube channel. And something interesting is that we hope to get more female listeners to this podcast because
Of course.
we had more males. But yeah, on that note, thanks everyone.
You mean guest, eh?
Yes, yeah.
So both,
Yeah.
both,
Yeah.
because we've got more male listeners or people that watch the podcast, males,
Okay.
females, but also we hope to have more female guests. So those two things.
Okay.
Yeah. Thanks,
Cheers.
everyone. Cheers.
Cheers.